We'll start with you, Peter.
Sure. Hi, I'm Peter McRae. I'm a psychiatrist by background. I'm a CCIO at East London Foundation Trust Elft. Hi, everyone. Donny, do you want us to kind of spiel off into things?
No, names first.
Right. Standard intro done.
Yeah.
It's James Reed. I'm here all week.
I'm Chris Reynolds. I'm not here all week, but I am the Chief Digital Information Officer at Sheffield Health Partnership University NHS Foundation Trust. As you can tell, we have just renamed our organisation.
So I'll come back to you, Peter, with what does it all mean? Neighbourhoods. What is a neighbourhood to you? And you're all going to get a shot at this, so fire away.
Yeah, so I guess to say at the outset, I'm not positioning myself as an expert, but Elft did start reorganising ourselves around a neighbourhood model when NHS England sent out guidance back in kind of 2019. And so we went through a transformation programme over 2 or 3 years where we reorganised our mental health teams around the primary care network unit, the cluster of GPs, the little geographies. So we created smaller teams, each of which served those areas. And probably the biggest change is that we brought voluntary sector workers into those teams. So we gave them honorary contracts and they were in the teams with the title of kind of community connector, sort of social prescriber, but also sort of linking out to other organisations. And then we've been working on trying to have better connections with primary care and with GPs, not always hugely successful. And Elft covers 3 different boroughs in London and Luton and Beds. And we have quite different arrangements in each of those areas with different Section 75 agreements in most. So it becomes quite a complicated series of fiefdoms in Elft, but I think the main aim for the neighbourhood model is that kind of basing it around the PCN clusters and trying to get the voluntary sector kind of inside the team. That's what happened before, and I guess maybe I'll let other people say what they think of the neighbourhood model is. We're also doing one of the new pilot sites for a kind of neighbourhood hub, which I could talk about.
I don't know what they're calling them, but are you one of the official? I don't want to say Vanguard because that was from a bygone age.
Pioneer site, yeah, maybe. So ours is called Barnsley Street. It's in Tower Hamlets. It's like so it's based on the Trieste model, which people may know. Italian model. It's supposed to be kind of much staying away from coercive intervention, a much more open shared space, trying to avoid people kind of escalating into crisis, part of the kind of left shift of supporting people in the community. So this pioneer site is a building that was owned by the voluntary sector that our NHS team sort of moved into. So it's a sort of shared space. It's got guest beds, quote unquote guest beds, can't call them inpatient beds, a small number of beds for people to use temporarily as an alternative to admission. And it's very dependent on just having the right mix of kind of probably more people than usual to try and provide that support in that space. But that more people includes the voluntary sector as well as health staff.
So
James, as King of Birmingham, what's your neighbourhood doing?
Yeah, well, fiefdoms is probably about right, actually. Yeah. I mean, certainly we've got an interesting arrangement because unlike a lot of places in Birmingham, the mental health trust and the community trust are separate beings. So we've actually got a common CIO, which is interesting, but they are separate organisations. So the community trust has done more of the neighbourhood type work. So they have got a concept of integrated neighbourhood teams, similar kind of idea. I mean, there's one in Washwood Heath, which is sort of east of the city, and that's been on BBC News no less, because they've established quite a nice idea of a sort of command centre that sits with lots of screens and data on where they're looking for frequent patients attending A&E and being picked up by the ambulances and stuff. So they're trying to do a particular piece of work on that, and then that model's being replicated out. And we are, at the moment, they use it off spreadsheets, but we're going to feed it off our shared care record in due course, which will be quite an interesting piece of work. So there's that going on. We're doing, I haven't heard Pioneers before, but we're also doing a version of the Trieste model, which I've always thought is curious. I have to be a bit careful what I say, but it's not the Italian model, as I understand it. It's the Trieste model. So obviously, Italy didn't seem to make it work. No, exactly. Yeah, that's right. So anyway, we're doing very, very similar idea. We've taken over an old building. We haven't got beds in it yet. We call it the 24/7 service. Although from what I gather at the moment, it doesn't actually run 24/7, but that's the aspiration. So that's an interesting idea. I mean, we'll see what comes of that. I mean, the advocates will say this is the way that mental health care should be done across the board. I think I'm maintaining. Actually, I'm agnostic, I suppose I'd say at the moment.
How big is a neighbourhood?
Yeah, well,
Chris.
go on, Chris.
I have a number. I was told by my lead, James Sutherland, I think he tells me that he's part of the NHS England stuff, and we've got a 2-year project. We've got 5 million quid to invest in that. We've got, he says, population of 50,000. It's appropriate to a PCN size. We are effectively taking over an existing building. Used to be, so it's got GP practice, but there's a library, and we are renovating that space. Again, very similar. Safe beds. We're calling them safe beds. So
as opposed to
inpatient beds, yeah, because they're not for inpatients.
So 50,000. That's an area health authority and old money.
Yeah, and it's about 5 or 6 GP practices just in a little geographical cluster. Yeah.
And I guess one of the things that we've been very keen to do is the feedback from our patients and our stakeholders and our carers and wider is that we wanted it to be really clear there's no wrong door here. So it doesn't matter to us effectively if someone from outside the 50,000 comes in, we are going to treat them in exactly the same way, make it so that boundary isn't there as far as we possibly can. So
okay, that's interesting. It's the first time I've heard a number put on it. So are you is everybody establishing sort of neighbourhood, mental health centres?
I mean, not exactly. We've embedded. I mean, a bit like others, we've embedded our staff in general practice directly. So they've got these. Again, I think they're called neighbourhood teams. But the idea is the first point of contact is meant to be one of these embedded workers rather than going straight to the mental health trust. That's the principle. And we have got those pretty much everywhere in one sense. So they're kind of practice or PCN based. Sometimes they move around, and then I think that's had a lot of. They've seen a lot of patients. I don't think we really yet fully understand whether that's reduced our referrals or not, or whether it's just delivering more care in primary care.
Yeah, that was almost our model before the neighbourhoods, though. We had kind of link workers who would be sitting in the GP practice, basically being useful and helping with communication. And then we moved to something that was more just within the neighbourhood and put a bit more onus on the GPs having to drop in. And that's been one of the least successful things, really, because they haven't had the time to just drop in. And so we've sort of gone back to a slightly more traditional liaison model for the GPs. It's the space is very much as you've described it. And I think that's one of the issues with challenges with how we make digital systems work, is that we're trying to do both convert people who have been with a traditional CMHT model for a long time and are well known to us and provide some aspects of that service, whilst basically allowing anybody to walk in off the street and be supported and have a chat and then potentially drift off and never be seen again. And, it's an NHSE pilot. So how do we evidence what we're doing and what we're doing is of value, and how do we capture that those people coming in have done something meaningful or useful? So our systems obviously aren't very well set up for that. And you're kind of so some of it is almost like just group-based activities. Yeah, I still some people to do this, and that's kind of as much as we can get for somebody that wanders off the street and we never even know much more than their first name, versus at what point do you start registering somebody, and kind of providing a more kind of standardized.
It's a real headache for me, that, actually, because of course the principle of it, it's difficult, because on the one hand, with my system type, I'm saying, but you can't do things like that. Of course you've got to register them, of course you've got to add a referral, of course you've got to add activity. But at the same time, if we're trying to, as these models are, trying to do something that's genuinely different, you've got to be willing to let them do something different. So we've met a compromise that's got somewhere along that line, but it remains to be seen how that will work. It's almost impossible to keep detailed, accurate clinical records with a model, like you say, based on people coming in for a bit of hospitality and staying around, having a chat, and going away again.
Yeah, and so the bolshiness has come from the clinical team that are running the pilot site for me, which is quite helpful. I don't have to be difficult, because they're more than ready to say I'd rather not use any systems at all. That's very much we just spend time with the
certainly
patient.
Said that. I think that they regard their view, and I had some sympathy with it. It was the tyranny of clinical records is what was preventing the delivery of good mental health care.
So, who owns the buildings then for these neighbourhood
Yeah.
health centres?
Well, our one is a charity owns it, I think, and they it was out disused, and I don't know if we're renting it or we're certainly refurbishing it for them.
And as a former medical director of an NHS trust, who's in charge? I'm fascinated by the governance.
So I think in our case, I mean, we've received the money. So roughly it goes through our governance, but it is a very, very collaborative piece of work. So we have the local council involved, we have all the VCSEs involved, we have the GP practices involved. Ultimately, who'll be held to account? My organisation, no doubt. I think one of the interesting things is the feedback from stakeholders has been that, they don't really want to talk about it being a mental health centre almost. Yeah, because that stigmatizes. They don't want to feel that is what it is there for. And that stigma is still around. And, so we considered at one point building a new build, but that would be the mental health building with our mental health logos all over it. And that's why, in the end, we've not gone down that route.
Looking to the future, there's talk of integrated care organisations, and will the neighbourhoods be chunked up into integrated care organisations?
I think you need to ask NHS England, Joe.
Well,
I'm not sure we can answer that.
I'm not supposed to express an opinion, but I'm genuinely not. I wonder if I'm alone in being befuddled about the overall plan. I'm not.
I mean,
Is there one? Is there a plan?
I don't think. I think deliberately or otherwise, quite a lot of these early sites are doing things quite differently. I think they haven't decided on the model yet. I think they are looking to see which bits work before maybe creating some kind of franchise model that we might do more broadly. But at the moment, I don't think there is that kind of a plan about quite how they would work. Not so much this change in the Barnsley Street that we've got, but the change before, I think, when we went to the PCNs, we found in my borough where we work that actually that size of team based around 6 GP practices is actually really hard to maintain in terms of sickness absence and changing people's roles. Actually, it's very easy for a team as small as that to lose the capacity to function. And so actually they're starting to amalgamate into kind of joint teams now, still based around 2 PCNs, but like slightly more back towards a traditional model, just be able to have the capacity to deliver when things aren't perfect. So, I mean, I think there's always going to be that mix, isn't there? We'll get some kind of description, but then it'll be just left to everybody to decide locally what they think that
It does seem a relatively small unit in terms of it wouldn't be difficult to fatally wound a 6-doctor practice, and it just seems like a very small unit. I know small is beautiful and sometimes big is beautiful, and we cycle between the two, but that does seem a small size.
It does depend on your geography, I suppose. I mean, again, obviously in Birmingham, everything's kind of heavily concentrated into small areas. So, you can. There's less of it. We're in a big geographical area. You have a different approach. Your units will physically be bigger, even if there's similar numbers of people.
Yeah.
As an example, I've become a frequent flyer in the health service over the last couple of years with my mother, who's 92 and has dementia. And a broken hip and many pathologies. And the team around her, which I call the Constellation of Care, come from many different organisations and at many different levels. There's a consultant psychiatrist or two, there's a physio department, there's district nursing, there's the Little Sisters of the Poor, who run the care home that she's in. How do you join that all up, from a neighbourhood point of view? How do you, those care teams are very distributed across many organisations, and you've got this huge constellation of care around the patient. How are the neighbourhoods going to cope with that?
I would guess that it's probably not for the example you give. It's much more for, I think the intention is to keep away from people getting much worse and treat them. Obviously, all the evidence says that if you deal with mental health issues very, very, very quickly, very
whilst they are low level, then you will get better outcomes. And that's why we had improving access to psychological therapies, which is, you may have different opinions about it, but it's there, it's helping. I don't think you would see an in-reach service from a neighbourhood hub into a care home. I can't see that at the moment, but maybe it will happen. I'm not the expert on it. My clinical colleagues may have.
I think the answer to that question to some extent is about you've got to build some kind of common platform, a common language. Now we've definitely been trying to do that. I mean, there are a number of organisations that provide solutions for doing this. I mean, it's usually, in our case, it's under the banner of the shared care record, but we have built deliberately a platform that's not just about health, it's about health and social care and thirds and everything. So we built our data sharing agreement to be as inclusive as possible. And we have got, so in Birmingham, CGL, which is a well-known third sector addictions charity, they've built a first-to-type interface. So we now get their data, they get our data. We've got the ambulance, so we've got hospices. We would see the solution to this in the end as being, if we're going to have a common care platform, we have to have somewhere to go that's not your system that everyone can see. Like end of life is another example. So the famous respect forms, they just don't work on paper because everyone's got their own version of them. They only work if you can have a single. So I think some kind of technology platform that everyone can get to, you've got to have that if you're going to do this.
WhatsApp.
Yeah. Well, but the communication is, so like in London, we've got the One London shared care record. And so it sounds like the single patient record might end up be different in different localities and might be for us some sort of beefed up version of the shared care record, but it doesn't, what we also need is some kind of active doing bit with workflows and tracking and communication and being able to see that things are collaboratively handled between the different organizations and we all contribute. And so that platform doesn't exist at all for the moment, and I don't know where exactly that's supposed to come from. I thought maybe it was coming from.
Funny you should say that.
Yeah, well, former occupation, but so there's the single patient record idea, but I think that's more along the lines of accessing the information. There's the federated data platform gets brought up, but that's probably more analytics, maybe some modules, but probably not that solution. So there's like a third thing.
Yeah, there is.
Needed to be able to knit the organisations together.
It's really interesting because this is the piece that's missing. I thought I'd be really clever putting in the Great North Care Record in the Northeast so that my mother's health records can be seen anywhere by anybody in the Northeast. 3.5 million GP records shared, 12 trusts, 8 local authorities. I thought I'd sort of fixed it very smugly. But in fact, the physio will still turn up in the care home while she's at the orthopaedic outpatient clinic, because they don't know that information isn't shared. Yes, you can go and have a look. It's brilliant. It's a giant leap forward, the shared care record. But it doesn't integrate your care. It allows the clinician to see lots of stuff, but it doesn't actually integrate care.
Well, it can. Well, it's the thing is where I think we've maybe missed the trick with shared care records is just thinking of them in that sense. Because if you build a data platform more generally, you can do stuff with it. So in ours, as well as you've got the, again, it's other products are available, but ours is an InterSystems product, but that has the clinical bit that lets you see it, but it's also got a module that lets you collaborate on care plans and involve patients and because it's an integration platform at its heart, and you build different applications on top of it to meet whatever your needs are. So we've done exactly that thing around collaborative community care planning. It's the one thing that everyone can see. It doesn't matter what your local system is. You can all get to this central point, and you can all start to do some things which need to sit away from your local systems in a central place. And I think any shared care record platform is the building blocks for doing that. And we've talked a lot about, smart on fire and separating the data from the application, all these buzzwords. The capability exists if we want to use it.
Okay. We touched on the voluntary sector very briefly, but I'd like to come back to them and ask each of you, actually, how do you integrate the voluntary sector? The Little Sisters of the Poor can't afford Epic.
We've sort of not tried to solve that problem by just having those voluntary sector people join our teams, really, and have access to our system, and ours becomes the place where that activity gets documented alongside everything else. So it's an unsophisticated way to go about it, but that's how we have their
and
in our system.
Do you do you limit their access? Is
No, and not in a meaningful way. No, because I mean, we're still, I think, like most trusts, the majority of relevant clinical information goes in the progress notes, which is where they go to put information in. So no, they can see that information too.
James?
Yeah, so we've got a mixture. So it's all about scale. So if you've got a very small organisation with a handful of employees, the simplest thing to do is just extend the tent round, give monetary contracts, and bring them in.
Our back is dead.
Well, I have to say, we've got 2 roles, I think, and that's it. Because I've never liked the whole art.
I'm okay with it being.
Yeah. Because I think if you're seeing a patient and you're doing something with them clinically, well, in the broad sense of clinical being by the bedside. In other words, I don't like getting into these clinical versus non-clinical arguments. If you're seeing someone and doing something, then you should have access to all of it. Why shouldn't you? Because then you get this strange situation where one person knows more than someone else, and you only know after the fact whether they should have known whatever it was. So we don't do much of that. And so that's what we do for the smaller. The bigger organizations are more difficult. So the likes of Mind and the big charities, they've got their own platforms, their own systems usually. Often, I think Mind use one called Views, which is in-house. And then we have a problem just now where we've got some joint enterprise, and Mind want their staff to write it in Views, and we want our staff to write it in Rio, and Mind won't give us access, and it's too many staff. So we've been trying to influence them to say, why don't you use this shared care record thing we've got? But getting them interested in doing that is not always easy. I mean, CGL were really keen and really pushed it, put a load of resource in and made it happen. Up until now, anyway, we've not had a lot of enthusiasm for any of the other large third sector providers.
Chris, voluntary sector?
I mean, we made a deliberate decision not to ask our VCS colleagues to fill into a mental health patient record. That's been and what we're aiming for is integration. Now, the shared care record is definitely something we want to explore in terms of giving them access to that. My organisation's only just gone on to Rio, and we haven't done the shared care record yet, so we've still got that piece of the puzzle to fix. But we do see it, I guess, as it's a really big challenge for Joe McDonald's Allotment Society, isn't it? Because how are they going to record what they do? Do they even really want to? But wouldn't it be nice for us to know that for a cohort of patients that really works for their mental health? Yes, it would. But this is why we're piloting, I think.
You run the risk of choking the life out of it, don't you? If you say, never mind all that good work. I mean, you've got to write it all in the notes, Yeah. And that's not a world we live in. In our world, writing records is a big part. But if you're if you're just out there seeing somebody working with them, that's not a thing that you do, is it?
Other organisations. I remember 10 years ago when we were doing early workshops with the public about Great North Care Record and record sharing. We asked people who they were happy with things shared with the doctor, of course, the hospital, of course. Social services, oh, all right then. The police, and one of the members of the public said, "Oh no, that's over the creepy line." Yes. Where's the creepy line in terms of information sharing in a neighbourhood? Where's the edge? Is there,
I think that's when you do start getting into more nuanced discussions about the what, because I mean, obviously the police is a good one because there is, whether you like it or not, there's a big crossover between police and mental health. Well, I mean, it's in the Mental Health Act,
Yeah.
And we've got, like most places, Section 136s are a big issue, and what the police know and what they know when they pick them up. We've done a bit of it. We've got a street triage thing here, which I think other places have, where you've got a kind of a soft interface where you all sit together and they talk about the cases. And that's
when you go into a house with 6 cops, you've shared some information with the police, haven't you?
Precisely. So we've always thought that police, fire brigade, all the rest of it are on the agenda thing we'd like to do. We haven't found the way, and in fact, we haven't really had much interaction, say, with the police about it. It's a conversation I'd love to have. But again, like all these things, you've got to have a way in somehow. And I've not found that yet.
I mean, I think for us, the edge is the partners we're working with at the moment. We work with the council. We work with Sheffield Flourish, who are a small charity. And we work with a variety of VCSEs, work with Sheffield Children's as well. We haven't put the police within our set of stakeholders at the moment. So at the moment, we would be going, okay, it's, standard practice in terms of clinical care if that is required. But I do think what we're trying to do here is not the extreme end of mental health. It's actually, we're trying to get it right up front, aren't we? We're trying to make sure that people don't get into those situations right up front. Sometimes they will, of course.
So in order for the neighbourhood concept to work, then clearly the single patient record is the way to go. Discuss.
A single patient record, whether the single... But a common platform is needed, for sure. But whether that's...
National?
It doesn't need to be national. It doesn't all need to be national. Because again, this is the thing sometimes where we got tripped up is that most people receive care mostly near where they are most of the time, and the further away you go, the amount of crossover does drop off. So if you're not going to do the whole thing, if you focus it on your local, you'll still do most of it, even if you don't do all of it.
Yeah, my understanding is that we've already sort of given up on that, and that people are just trying to look to bespoke the local solutions and build them out into something that's closer to that vision. I think we still just have the battles to, we're not worrying about the more peripherally involved organisations. We've got 7 or 8 local authorities with different information sharing agreements and dual entry into systems, and how do we share with them consistently while they share care record. So I think what we'll be doing is just trying to get our shared care record fit for purpose, actually connected across London, not just into our most immediate local partners.
I mean, there's great work that's gone on, isn't there, in the shared care records?
I mean, it's brilliant what it does.
I'm not really an apologist for the NHS England on the whole, but the National Record Locator is a thing I've badmouthed for years as being vaporware and never going to happen, and it has actually happened to my surprise. So we're both. So it's in principle, and it's like a telephone with you got to have someone on the other end of it. But we're flinging out stuff onto the National Record Locator now that, in principle, anyone in the country can see an international patient summary for our patients, medication lists, crisis plans, and I think that's probably good enough. You're not gonna need to put absolutely everything out everywhere, but if you've got something out everywhere, and there is this platform that exists, that's probably good enough. It maybe not perfect, but good enough.
Chris, single patient record?
Are we in danger of a solution looking for a problem? Maybe, perhaps. The same with AI, a little bit. We've got existing infrastructure on shared care records. Let's build that technology out, and spread it as much as we can. Because the classic thing is, these things take time. It's cultural change, going back to the previous conversation, previous round table. It's always cultural change. So it is always going to take you a long time to do these large-scale things. Now, obviously, locally, you should be able to go quicker than you can go nationally. Yeah, that just makes sense. So why not sweat those shared care records? Why not have being held to account to use them on our public sector bodies? That might be more of a help to long-term care of people than creating something centralised. But we are in the lap of our NHS England colleagues on that one. And Rachel may say something today. She may
be saying it right now.
She might, yeah. She
I
might.
suspect. Just to finish up, where are you going, Peter, with your neighbourhood at the moment? What's the next 12 months look like?
It probably depends on what the money over the next 12 months looks like. I mean, we've got this test site. We're figuring out what's working. They haven't got all their beds live yet. They haven't necessarily got all the data coming back in that they need. We're just trying to make that work, really, and learn from it, and then see whether or not we'd scale it up. And in the meantime, things are happening that are slightly disconnected in our other boroughs. And so we'll need to just think, is this sufficiently successful that we can use it to advocate for a business plan that says this is where we'll invest in people, this is the kind of technology we'll be implementing, these are the kind of spaces we'll need to buy in all of our different locations. So I think we're just looking to get a bit more central clarity, and then kind of be confident that this example that we've been making on Tower Hamlets is something we can scale up.
Okay. James?
Yeah, it's similar sort of thing. So we've got, the community trust interaid neighbourhood work's going to carry on, and we will see that move and reproduce itself across the city. Then the 24/7, so our sort of pioneer project, well, the same sort of thing. Let's see. They're just about getting their building established, and we'll see what happens, and it's going to be an interesting journey.
Chris?
Yeah, so we're finishing off the build in March. Then it will be all up and running.
How did you get your £5 million, Chris? I'm sure everybody would like to know.
No,
That was the thing,
I
wasn't
didn't.
it?
I didn't. It was
We all got it, didn't we?
yeah,
For these projects.
yeah. So
Okay.
yeah, of that order. We're investing in our peer support workers, so 250k is going into them. We're investing in the local voluntary sector organisations to the tune of 150k, and hopefully, when we're sat here this time next year, we'd be going, oh, okay, now we can see what's happened, what the benefits are, has it worked a bit, what are the results?
Okay, thank you. I'm looking for Laura, who's not there, to ask her if we've got time for questions. We have. Have we got any questions?
Thank you. In danger of making this a political question, and seeing as somebody else has already mentioned Rachel Reeves, in light of the fact that the government have released a 10-year plan, how concerned are you as clinicians and leaders in the NHS that we'll never get to realise that 10-year plan because in 4 years' time we'll have a new government with a different political agenda? And secondly to that, do you feel like the NHS is now becoming a political tool? Thank you.
I did about becoming a political tool. I mean, I think the longer you, I mean, my colleague John Farrington, who some of you will know, has an excellent presentation in which he lists out all the plans that there've been over the last 15, 20 years. And I mean, I think at my age now, these things come and go. They're like the will o' the wisp.
There are at least a dozen 5-year plans in
right.
the last 15 years.
And no, they're never finished. No one ever says, well, we finished that plan. So it kind of, I have to say personally at least, I let it wash over me. This thing's we've got a job to do in front of us. I'm more and more these days focused on the job right at hand that I've got to do, and I'll do that bit, and whatever happens over there, well, whatever, but I've still got a job in front of me to do, and that's what I'm focused on.
Yeah.
I mean, I think the standard view when people read the 10-year plan was that it wasn't a plan and it was a set of aspirations with no necessarily any route to them. So that should be fairly straightforward, shouldn't it? And not having to change plan. Focusing on the NHS app as a progressively more sophisticated front door seems like a good idea. So hopefully we keep moving towards a more functional NHS app, something that is what we've just been talked about, something that supports integrated care in neighbourhoods. Seems like something we would continue to pursue as realistically has been the aim for the last 5 to 10 years. So I think, much like what James is saying, it's just another stage in some kind of similar messaging.
Yeah, I guess it is a political document in some ways, but it's aspirational. I'd agree with the speakers on that. And our job as leaders is to try and take the good out of it and do the good things that we can do to improve care, and that's why we're here. So, to a certain extent, there will be another government, there will be another plan. I don't think it's going to say go back to paper, so I'm happy.
So we're all right, Jack.
Yeah.
Have we got another question?
Hi, I'm Kaylee from Gloucestershire Clinical Systems Change Lead. Just back to, I think I've forgotten name, so sorry, but a person from Sheffield. You mentioned earlier that you don't let VCS staff access your clinical systems and records. So I was just curious as to sort of the reasoning around that for why. I mean, we've jumped from one side to the other in our organisation, and the impact that potentially has or you see have on care delivery. And secondary to that also, is it a similar approach for the peer support workers? So we are seeing an increase, as you are, with peer support workers in our teams. And again, we have that sort of question as to should they have access to the records, and if so, sort of what training and what access?
Yeah, so I'll be
On the spot,
clear.
Chris.
Yeah, I know. I feel like it. So the decision about whether they have access to the mental health record is partly driven by the fact that we were implementing Rio at the same time. So there's a practical consideration there. It's smart card driven. So then you've got to give smart cards to everyone. If you're going to record activity, Rio is lovely, but it takes time. And that isn't a as I say, in terms of doing an innovative new service, as we've talked about, it didn't feel like the overhead justified the effort. And it may be that we take that decision, and because it's a pilot, we might decide to do something different in the future. I think probably what I haven't talked about in the model is there are a lot of mental health workers within that space. They will all have access to clinical records, clearly. One of the key things we're trying to get out of that pilot is to stop a revolving door through our own services, effectively. So trying to get people who need to be in crisis or talking therapies quickly there, rather than referral into this team, then referral into that team, then referral into that team. So there's a very mixed group of specialists behind our mental health offer, if you like, in that building, so that we hope will deal with the mental health care side.
The thing about mental health is that we have a fuzzy edge from an information governance point of view. It's really fuzzy.
Yeah.
And you often have to make those individual creepy line decisions.
Yeah.
Is it over? Is it the right side? They're really hard. I don't think there's a right or wrong answer in the fuzzy edge nature of mental health. And you do have to do a certain amount of case by case.
We got into a bit of a pickle with peer support workers, actually, you mentioned them at one stage, and there was a lot of enthusiasm, which is fine, but it kind of, I don't think they hadn't always been thinking about what that means. So if you have a peer support worker who's working with a group of their peers, like patients they know well, who they're on a ward with, for example, and then you give them access to their peers' records, it's difficult because they then, you could conceivably be providing them with far more information than they really needed to know, which is unusual.
And they haven't had the IG training, and they put it on Facebook.
Yeah, and we did. I mean, it wasn't quite like that, but we certainly had some. It could have led to things getting very different, and we managed to deal with it. But it's just always being mindful of that. To just especially once these people become staff members, because the normal line is, well, staff members fine every year, but you just have to be aware when you're doing that kind of work of just making sure you consider it all properly and don't allow things just to get out of hand. And often you do get certain groups of enthusiastic staff charge off down one line without necessarily anyone else realizing what's happening.
Okay. Got time for maybe one more question. Stunned silence. Oh, no. Oh, blimey, two at once.
Two at once.
Like buses, isn't it?
Yeah, I suppose on the subject of neighbourhood mental health and where you've used shared care records, have you done anything around patient cohorting and looking at things like patient need groups and being proactive and in the preventative space rather than reactive?
No.
Not a little bit.
No.
Oh, there you are, Mark.
Go on then.
Come on then.
What have you done?
Come and stay here.
I just wondered if anyone else is doing it. I mean, so one of the things with our shared care records comes back to what you were saying, James, was it's a data store and an interop opportunity. And so if you put for people who don't know what ACGs and patient need groups are, it's basically a score developed by Johns Hopkins University Hospital in the US. And it enables you to start to prioritize your patients. And if you then start to look at conditions and you look at activity, so a classic for us is what happened to the patient pre-A&E and post-A&E. And it starts to tell you how many times they'd already gone to their GP with their mental health issues, how many times they'd materialized in our crisis teams, and what we did about it or didn't do about it. You can start to stream that data, which is really quite interesting then to start to say, take that patient, that cohort of patients, and do these things earlier, and then they won't turn up in A&E, for instance, and get it back into the neighbourhood piece.
Interesting. We have one more question.
Just on there in London, our shared care record isn't that repository at the moment. It puts a call out to the systems at the point at which you try and find out about a patient. But there is a secure data environment being proposed, I think, for that reason to do the equivalent, so that it would be the repository that you could then do that kind of segmentation analytics on.
It's the prickly version of all this neighbourhood stuff. And for me, neighbourhoods are a little bit over the creepy line already. I don't really want all of my business to be accessible to whichever VCSE person sets up a little thing and then joins the shared care record. Now everything, access to everything. But the prickly side is the people you might deal with, James, the predators.
Yeah.
The actual sexual, violent, financial, whatever it is, kind of, genuinely nasty people that are around looking for opportunities to take advantage of us being a little bit, grey and helpful around the edges. And I can't see that it'll be too long before these nice, safe spaces might not be so safe in some spaces. I don't know how you've tackled that or would suggest that we try and tackle that to keep them as safe spaces.
I think that's a great point, Paul, actually. I think the main thing to do is exactly like you've done, is to own it and actually just be honest about the fact I think it's easy to get caught up in ideologies sometimes, isn't it? And doing everything, isn't it great? And it is, but you've got to, I suppose, again, especially in my kind of line of work, you do tend to see where things have gone wrong more than others, but it's just being honest about it and raising it and making sure that when you're building stuff, you are at least considering the prospect of a bad actor effectively. And what that would mean. I think we do it all the time with clinical records, don't we? We say we might get a bad actor, and you can only do so much to put. At least you own that it's a thing that could happen, and that's the most important thing to do, I think.
I mean, the other thing is, of course, that when we were on paper, we couldn't see what the bad actor was doing. Now we do at least have a chance.
Well, yeah, for sure.
We have a chance to spot that they're in the wrong record at the wrong time, doing the wrong thing. So it is a measure of progress, but I think it's a good point, well made, and I think we'll finish there, and we'll go into a 20-minute round table about neighbourhoods. We'll suck up all the knowledge in the room about what's going on in neighbourhoods and what we think neighbourhoods are, and feed that back. So we'll give you 20 minutes on that. Round of applause for my excellent panel. Thank you.